Thank you, Robin. It's really a highlight each year to come to the NAMI group, and typically I do this in the fall, so September, October. We're getting close to Halloween now, so we had to get it done before the end of October, I guess. Of course, it would be much nicer if you could all meet in person, and I hope that soon we can do that again. I really hope that next year in the fall we will be able to have a NAMI meeting in person. I wouldn't have thought that we would have 2 falls without an in-person meeting. So, aren't we going to walk also in person next year, Robin?
We're working on it.
So I can't wait.
Mm-hmm.
So I've been a member of NAMI for many years. I joined it when I was still up in Boston and thought it was really important for me as a psychiatrist to also understand mental illness from the perspective of the person who is affected by the illness. And that is not just the person who we refer to as the patient, but all of the people around them, the family members, the friends, the co-workers. So, and NAMI really is the one grassroots organization that has understood that and has made it a significant effort to educate everyone, including the professionals, about what it feels like to have an illness like psychosis. All right, I will start sharing my screen and share a couple of slides.
All right. Are we sharing or not? Yeah, there we go.
Now, can you see the full view with the slide?
Yes, we can. I can. I hope everyone else can too.
All right, very good. So the title is a little bit longer than usual. Typically I have short titles, but this time is Coordinated Specialty Care for Early Psychosis Patients. So I will talk a bit about coordinated specialty care, and there are actually 2 team members on this call who are actually going to help me explaining what coordinated specialty care is. And that's Kelly and Emily, and we will introduce them in a little bit. But before we do that, I would just want to get everybody on the same page to understand what early psychosis means. I think we all have an understanding of what we mean with psychosis, but it does matter to spend a couple of minutes to go into the details, because if we really want to help a person who experiences psychosis, we need to know what we are talking about with that word. It's one of the most complex words in medicine. So most people would say psychosis is delusions and hallucinations. That's what most people associate with psychosis. And that's true that the majority of people who experience psychosis either have sensory experiences, meaning they hear things or they can see things that is different from what other people around them can experience, or they have beliefs that are different. And not only do they have these beliefs, but they also act on those beliefs. So that's what we refer to as hallucinations and delusions. But it's not all. But about 80% of the people who experience psychosis have hallucinations and delusions. There's also this disorganization of thought and of behavior. And it's really a little bit more difficult to explain. The disorganization of thought is pretty apparent. And most people who have this will have a difficulty communicating. Their thoughts might be too slow, they might be too fast, they might be jumbled and disorganized. They might find it very difficult to pay attention, but not to the degree that it's mild. It's to the degree that it really makes it hard for the person to communicate. Disorganization of behavior is a little bit different. And that actually comes in many shapes and forms. It can be a person not talking and not moving at all. That is a very severe form of disorganization, but it could also be more subtle, where people don't take care of themselves. So those are the 4 major features of psychosis. And then there is a fifth one. It's what we refer to as the negative symptoms. And that is typically a combination of a lack of drive, a lack of will, and that's the technical term is avolition, and flat affect, people not experiencing joy, not being rewarded by things that most people would find enjoyable. Both together make up the negative symptoms. So you can see now, this is rather confusing. This is all meant when somebody has experienced psychosis. It could be all of the above, or it could be just one of those 5 things. So it's rather confusing, because if you say a person has psychosis, you would need to know what exactly they experience. Now, for us in psychiatry, we spend a lot of time trying to understand the causes of psychosis. And of course, we are primarily interested in distinguishing different types of mental illnesses that can lead to psychosis. And the 2 more well-known ones are schizophrenia and bipolar disorder. Both of them can lead to psychosis. And then, of course, we are particularly concerned that sometimes, particularly in a young person who's never had psychosis, who develops psychosis when they're 18, 20, 25, we want to make sure that we are discovering these rare instances where there is an underlying medical or neurological condition that can lead to psychosis. And there are many. I'm not going to talk about that today, but it could be as benign as having a thyroid condition. And so or being on a particular medication for a medical condition can make a person psychotic. A lot of people who are put on steroids for pain can become psychotic. So we just knowing that somebody experiences psychosis doesn't tell us very much. We really have to spend a good amount of time to understand what type of psychosis and where it's coming from. Now, we have this book called the DSM, the Diagnostic and Statistical Manual. That's a book that outlines all of the different diagnoses that we have. And here they are. And you don't have to worry about them. We are not going to spend any time explaining all of the differences, but they all would be considered psychotic disorders. It's a little bit more important to understand that psychosis is just one piece of the puzzle. So if you look at this graph here on the left, labeled A, this should represent in a radar plot, that's what they're called. So just imagine on a radar screen, you can discover things. And this particular person has been experiencing a lot of hallucinations. So you can see it goes all the way to level 4, which is the highest, which would be severe. But the person also has delusions and just a little touch of disorganization of speech, and that's it. And also some difficulties with memory and attention. We call that impaired cognition, and some mild depression and mania. That would be a typical presentation of a person with schizophrenia. But on the right, another person might have the same blue, meaning the same psychosis, but much more prominent depression and mania. In fact, that might be the more important pieces of the puzzle. And this could be a person with schizoaffective disorder or even bipolar disorder. So it does make a difference where the person experiences abnormalities. It's important for the treatment and it's important for prevention. And that's what I'm going to talk about primarily in this talk. All right, so enough of the introduction to psychosis. One more thing. Psychosis evolves over time, and this, you don't have to worry about all of the fancy terms. Just look at the colors. Just look at the waves. A yellow little wave, an orange, and then 2 red waves. And this is over the course of about 10 to 15 years. So on the x-axis, this arrow that goes from the left to the right, that's time. So this is a person's evolution of psychosis over many years. And only at the end do we develop the symptoms that I just reviewed. The psychosis is really at the end of a several-year process. Now that's very important to know. So it's very similar to other medical conditions where we might have a person with hypertension or with high cholesterol levels. And if that goes on for years and years, the person ultimately might have a heart disease, like a heart attack. So it's actually quite similar in psychosis. The psychosis is really coming out of the blue. It is primarily present in a person in the late teens, early 20s. And this person typically has 1, 2, sometimes 3 years of mild symptoms. We call them blips, like a blip on a radar screen. Blip means brief, limited, intermittent psychotic symptoms. So that's very important, because once we understand that psychosis evolves over time, we could say maybe we can go upstream, maybe we can catch it early, maybe we can intervene when it starts rather than years and years later. And then there's one other piece that's really important. So look at this graph and look at the top. Just imagine this is the entire population. Let's say the entire population of Davidson County, for that matter. And then out of that general population, all of us, everyone, we have a couple, maybe 10% or so, that ask for help, that go to a doctor or a psychologist or a counselor and say, I have some difficulties, I need some help. And then you can see in color various individuals who will then be diagnosed. You can see there this gray arrow, diagnostic interview. So the person will actually be asked a lot of questions. And then based on that, we can make a diagnosis. And so we can identify people who are at risk for psychosis and then follow them over time. And then look at the bottom. Now you get 4 different scenarios, 4 different colors: white, green, yellow, and red. Out of all of the people that originally were presenting for help, only about 1/4, 27%, will ultimately develop psychosis. The others, while they also developed mild symptoms and are at risk because of a family history, because of trauma, because of various different conditions that they have experienced, like substance use, they might develop some psychiatric symptoms, but they will not develop psychosis. So just get this, only 1 out of 4 who is at risk of developing psychosis ultimately develops a psychotic disorder. In 14%, it's a small number, but it's more than 1 out of 10, go back and live normal lives. Although they have experienced the early stages of psychosis, they actually have what we call remission. So the symptoms disappear and they don't need treatment. So this is one of the most important messages for the talk today, that while psychosis is serious and can lead to significant problems, it is not a given that a person who develops psychosis will always have psychotic symptoms. So there's great variability. And that's why the approach that we are now pursuing, looking at recovery and looking at reintegration, is so important. So this is the summary of these courses, these different stages of illness. So at the bottom, you have the relapse and remission, which is what we often see in a person who has struggled with psychosis for years. They might have years of remissions, and then they might have years of relapses. The acute phase is when we typically see them in the hospital or in the emergency room. Something is really not working. The patient might need a hospitalization or might need more medication. And then what I'm talking about primarily for today is the first episode. So it is one of the acute stages, but it's the first time that the person will be diagnosed. And then there are these 2 stages before the person even develops the psychosis, which is the prodrome. It's typically depression and anxiety. So not hallucinations and delusions. Most persons who develop psychosis first start out with depression and anxiety. And then the at-risk state is when the person is much younger, maybe even younger than 10 years old, but is already at greater risk because of a variety of risk factors. All right. And then lastly, which I already mentioned, the outcome varies quite a bit. So there is not one outcome. Schizophrenia is often considered to be a poor outcome illness, but that's not true. And there is a good number of patients who meet all of the criteria for schizophrenia, but ultimately can do well. And so this rule of the 3/3 refers to 1/3 will always need treatment, 1/3 will always need treatment, but will actually do better in the end. And the 1/3 will be able to do fine even without or with very little treatment. There are some predictors that makes it more likely for a person to have a better outcome. Men typically do worse than women. If you have an acute onset rather than a slow onset, that is typically a better predictor. And if you have a higher level of educational achievements, and if you've been able to finish high school or college, that is also a good predictor for a better outcome. And then the last thing is a model that the British psychiatrists have introduced about 30 years ago now. And they were concerned about this early period that they refer to as the critical period, the first 2 to 3 years of illness. While it is true that a good number of individuals will completely remit or will do well in the end, there is one group where the symptoms actually get worse in the first couple of years, where the first episode is not the most severe. And it is that group that we are particularly concerned about, because there we need to do anything that we can do to engage the person and to provide the best possible treatment. So that's where the psychosocial influences, and that really means the family, the friends, are so important. So what are those interventions? What are those first episode treatments that we would recommend? Well, at the top, you see the title of that paper, the essential evidence-based components of first episode psychosis services. And on the right, you see this laundry list of 32 different factors that, of course, you cannot read because it's too small. So I've given you a magnified version of that. So there are actually, out of those 36, only 6 that are labeled A. And A means this is high evidence. This is high quality. This is what we would recommend. So I'm reviewing briefly those 6 components of successful first episode services. 4 of them are related to medication, and the other 2 are supported employment and multifamily group psychoeducation. So the medication-related issue is that you need to select the right medication. You should try to limit the medication to 1 antipsychotic. You should start slow and start with a low dose rather than with a high dose. And you should always consider clozapine for a person who doesn't respond to other medication. So those are the 4 medication pharmacotherapy related recommendations. Supported employment is what I'm going to talk about in a couple of minutes. And Kelly Vance is on the call, and she actually is our supported employment and education specialist on the team. And she will share with you kind of how she contributes to the team. And then the last is something that many NAMI members are familiar with, and that is the importance of psychoeducation. This particular form is called multifamily group psychoeducation. So imagine you meet once a week with other family members and you share experiences and learn from each other how to help a person with psychosis. All right. So this study, which came, this is now 5 years ago that the study was published. This was one of the most important studies that American psychiatry has seen in many years for psychosis. Again, it has this very long title, Comprehensive versus Usual Community Care for First Episode Psychosis. And this is a large study that John Kane from Long Island Jewish Hospital on Long Island was the lead investigator on. It was funded by the National Institute of Mental Health. So this was not funded by a pharmaceutical company. This was really funded by the government to understand what is the best treatment. And there are a couple of acronyms, a couple of names that you might have heard about. So the RAISE program, which is the NIH program, refers to recovery after an initial schizophrenia period. And that typically in this setting means 5 years of illness. So within the first 5 years would still be considered the initial period. And then the NAVIGATE, which is a name that has been used to describe this multi-specialty care. So what are the components? The personalized medication management, family psychoeducation, therapy that's focused on resilience, and the supported employment and education, sometimes referred to as SEE or SEES. All right. So here I'm going to just share with you in red boxes the highlights of this. So this is the NAVIGATE program that Kim Muser, who was at Dartmouth for many years, now is at Boston University, really one of the leaders in the field of how can we as a society, how can we as families help a person with psychosis? So I'm highlighting just the red boxes, shared decision-making, not deciding for the person, but with the person. Focusing on strengths, not on weaknesses. Focusing on resilience rather than on how stressful the illness is. Focusing on motivational enhancement, really crucial. Not take for granted that a person wants to take medication or wants to see a therapist. Starting out with the idea that this might take some time to motivate the person. Constantly educate, like what I'm doing now, but do it every single day with each person that you come across. If you have a family member with a mental illness, you will be an educator for the rest of your life, educating everyone about mental illness. And then the last is, of course, at the core of what NAMI does, which is the collaboration with natural supports, which are typically family, friends, and coworkers. So those 5 elements, these are the 5 key elements of NAVIGATE. And so the study that I just showed you used for the first time a clinical trial design, and basically said, if we compare the community care is here in green. So you can see those green dots at the bottom. That's the group that got standard care. And then the group in these orange dots, they got the NAVIGATE care. They got all of these 5 elements that I just showed you. And then here on the axis, you see the people that actually got supported employment and education services. So the question simply was to the consumer, have you met with a person who's helping you get a job in the community or furthering your education? So you can see that in regular community care, less than 20% of consumers of mental health services would ever be asked or would ever be talking to a supported employment and education specialist. So this program increased that rate to greater than 50%. And that stayed pretty up above 20 to 30% for the majority of those 2 years that the study was running. The other question was, have you had individual sessions with a mental health care provider who helps you work on your goals and look positively toward the future? So that's the resiliency training. And you can see that even in community standard care, you get a good amount of therapy. But this is boosted to almost twice the level in the NAVIGATE program. So very much personalized with a focus on recovery. Okay, so those are the 2 things that the person who is getting the service reports. And what are the outcomes? So those are the two major outcomes. And it's because of this graph and these findings that the federal government now has spent millions of dollars all across the United States to build new Navigate teams. So what are the results? So first is quality of life, QLS, and the other one is the positive and negative symptoms. So that's the clinical rating of how psychotic the person is. It's a rather confusing graph, so I want to just highlight the important pieces here. So the straight lines, you see those two here? The straight lines are the ones that matter. We can forget the ones with the hatched lines. So look at the straight green line. That's community care. So this straight green line is quality of life improvement over the course of the 2 years that the study was running. So this scale, actually, this quality of life scale goes from 0 to 100. So they were barely above break even or the midway point. But this increased from 55 to 65. And so this is in the group that got standard care. And now this is the other group. This is the group that got the Navigate treatment. And these two lines that have a straight line, they have a duration of untreated psychosis of less than 74 weeks. So what is that? A little bit more than a year? I don't know why they chose 74, but this is a group that had a shorter duration of illness. Once the illness has run its course for 2 years or more, the intervention is not that effective anymore. So that's what these two lines actually mean, these hatched lines. So this is the important difference here. A substantially greater going from 50 to more than 70. That's a very significant improvement in quality of life. And the same is true here for the clinical symptoms, the severity of psychosis. So this is where the Navigate people started, and this is where they ended up. And this is a much steeper decline of the clinical symptoms. So again, that's the severity of the psychosis. The higher the number, the more sick. Here it's the opposite. The higher the number, the higher the quality of life. So it's a little bit confusing. But here, going up from left to right means improvement. And here, going down from left to right means also improvement because you have fewer symptoms. And you can see that Navigate, again, leads to a steeper decline compared to the standard care. And again, if you have a longer duration of illness, you get more symptoms to begin with, and the intervention is not very effective anymore. So that's all I want to tell you about the study. This is really what currently has energized the field of schizophrenia research and has really encouraged a lot of state departments of mental health to invest in first episode programs. When we had our first episode conference in Tennessee, which was about 10 years ago, we had one program, and now we have more than 5. And of course, that's still not enough, and we only have 1 in Davidson County. We could easily benefit from 3 or 4, but it's a start. Okay, so switching to kind of the team, and then I will introduce also Kelly and Emily. So we really have 4 goals when we are helping a person with psychosis. We want to intervene in the acute crisis. We want to get them out of the hospital. We want to make sure they can live independently at home. Secondly, we then want to help them to do well in the community, typically with therapy and medication management as an outpatient. But then the important third point here is we want them to recover from the illness so that they can go back to the job that they had before, or train for a new job, finish school, or even start new educational programs. And then, of course, also avoid hospitalizations and avoid relapses. So this is, of course, a big team effort. This is not our team. We are all not that young anymore. But this is kind of the website for the Vanderbilt Early Psychosis Program. And we have a good number of people on the team. So we have a team leader. Most of the team leaders for these programs are social workers. That's also the case for us. So Taylor Gauthier, our social worker, is the leader of the team and brings us together every week for our team meetings. We have several therapists that includes PhD psychologists or massive peer therapists. Some of them are still in training. Some of them are very experienced with many years of therapy experience. We have a good number of what we refer to as medication providers, physicians, as well as nurse practitioners. And then we have these two very important team members that we didn't have until a couple of years ago. So we were much more old-fashioned standard care. But with Kelly joining us, we now have a supported employment and education specialist. And more recently, since last year, we also have our first certified peer recovery specialist. And I will actually stop sharing for now. I have just one or two more slides. And I just wanted to take the opportunity to just put a face to the name, because Kelly and Emily are both here and can tell you a little bit about maybe just how they ended up with us, how they even came to the team, and what their experience has been with us. If you wanted to maybe start, Kelly.
Sure. Hi guys, I'm Kelly. As Dr. Heckers mentioned, I've been with Vanderbilt's team now for about 2.5 years as the supported employment and education specialist. We also call me the CEAS for short, since that is such a long title. Before being at Vanderbilt, I was a case manager with young adults trying to find jobs and go to school. So as I wanted to do something a little more clinical, this kind of came along and I was able to join the team. But we've started this position completely from scratch. We've served about 20 patients in the past, on my team, about 20 patients in the past 2 years or so. And essentially what I get to do is I can leave the hospital and go meet clients wherever they are, take them to a job interview, work on their resume with them, take them to school to figure out their FAFSAs, all that stuff that can be really complicated and challenging, especially if you don't have people in your life who have done it before. I'm basically there to do it. We're also able to meet as a team once a week, as Dr. Eggers mentioned. So we all get together and talk about the patients and talk about their goals. And I mean, ultimately, when it comes to recovery, we want people to find some kind of meaning or purpose. And when somebody gets sick around that time of like young adulthood, when they're in college or in high school, it can be really hard to kind of like reassess your journey and figure out what you want to do in life. And I think our team does a really good job at helping people identify what those goals are. And then I'm able to just go out and help them do it like in a very practical way. So it's been I think we're a really great team. I think we've done a lot of good for our clients. So yeah, I think we've been pretty successful with that.
Kelly, maybe you could share a little bit. You just went through, I think, the second round of the fidelity review. Mm-hmm. So maybe you can just tell the group that this model, the supported employment education model, is quite robust and very well established, and there's an entire group of people who are making sure we are doing it the right way. Mm-hmm. Maybe you can just share a little bit of, because most people wouldn't know exactly how do you evaluate the quality of a program that focuses on employment and education.
So the model that we use, I think, came out of Dartmouth College. So it's been studied for years now, and it's a packet of guidelines that's about that thick. And it's pretty interesting because it looks, like a couple of the guidelines are like, you probably want to have this many people working at a time, But ultimately, it's more about like, is the team working together, and are you looking individually at each client? So like, they'll rate me based on how creative I've been with getting informational interviews with clients, and how I've been able to connect them with employers in the community, rather than if they really got the job. Because sometimes that's the hard part, is getting a job and keeping it. And I'm there to help with that. But also at that age, it's a lot of times more about the exploration. So the guidelines they give us are more geared toward, are we working individually with each client, rather than just, are they getting some job? It's like a 1-2 day review where we have to put everything together. Last year, or before COVID, we got a great score with that. This past year, they didn't do it quite the same, since we couldn't do things in person, but it's quite extensive.
Yeah. Well, and Kelly passed with flying colors.
Excuse me, Dr. Heckers, we're having trouble hearing you.
Oh, how about now?
Perfect, thank you.
Sorry. Thank you for letting me know. Yeah, and so just want the group to know that Kelly really has done an amazing job. And again, in the second time around, passed with flying colors, and they were very complimentary of what she has brought to the team. And really, this is important. She really has challenged the physicians, the psychologists, and even the social workers to think a little bit outside of the box and not think about the medical issues first, but more about the person's recovery with a focus on jobs and education. Emily, maybe I could ask you also just to tell the group how you ended up with us, because we were very fortunate to find you at Vanderbilt, but you hadn't been that long at Vanderbilt, and really we were benefiting from a really significant effort at Vanderbilt that was focused on substance use disorders. And because of that, we were able to get you also involved in our team. So if you don't mind, if you could just share whatever you're comfortable with.
Sure, yeah, thank you so much. Goodness, I kind of joked with Dr. Heckers when I took on this role that this was a very weird job to have, and I laugh about it because, you know, my role as a peer specialist is somebody with lived experience of having psychosis. I was working at Vanderbilt when I started with the team already in the addiction psychiatry program, where I still share my time with the Navigate team in addiction psychiatry. And so it's not every day you really put on your resume that you've, had experience with psychosis and have that be an asset. So I always kind of find a little humor in that, but I think it's a really unique, it's not only having experience with the illness, it's having experience with the recovery as well. And so really kind of leaning into, I think when we think about the Navigate model and leaning into the recovery piece and the hope that can be held and meeting patients where they're at. I think clinically speaking, I've learned a lot from the environment, and especially with my work with addiction psychiatry, for sure. Vanderbilt is a very great place to work, to learn how to, to learn. And so it's a really, in terms of the role, I suppose, with the Navigate team, what that looks like sometimes is offering lived experience, not so much with the psychosis per se, but with the recovery. I struggled a lot with having some cognitive impairment or having some disorganization. I was not the person that you were seeing speaking here this evening. I had my first episode of psychosis when I was 19 under the context of substance use, and it just rocked my world and everyone around me. And I don't know that I would have known that it would have gotten better, nor did I think that my family thought that at the time. And so it's very full circle to be in a role where I can help patients learn to have a voice and use their voice and feel like they have a voice in their own care. And also to help them understand that, that there's really just no judgment. It's just a judgment-free zone. I really enjoy working with the team because I really feel like all the members of the team get that. I can say from my experience you know, having been hospitalized, you can feel when a provider or somebody is with you or not. And I really feel that we have such a great team of providers, and no matter what the role is, you know, it's sort of, it's just, I don't know. I think there's just a lot of really cool things about, you know, all in all, I mean, I guess how I tell patients is more, I'm a person with lived experience of being in the hospital, and I've been a patient a long time too. And, you know, tell me about yourself, you know, what are your goals? How can we help you? And sometimes it's really just having them talk about a new TV show they like, or we've got a patient who didn't get a job he wanted, and sort of walking him through, you know, processing things like that, and sort of, you know, helping them use their voice in their families too has been big. So I'm not sure if there's anything else in particular you'd have me speak on, but that's kind of a little nutshell.
No, this was perfect. This is exactly what I hope you would be able to share. Thank you, Emily. Yeah. And I just have 1 or 2 more slides, and then we will open it up for a general discussion anyways. So let me just go back and share those last 2 slides. So I talked already about engagement and how important it is to not take for granted that the person who experiences psychosis wants to take medication, wants to go to a group or have individual therapy. They might also not be particularly interested in planning the discharge. They just want to get out. They don't care what's happening. They just want to get out. So there's no plan involved. And what happens is, if you don't plan it, then a week later or a month later, the person is back. So it takes engagement for all 3 pieces. Of course, there's more to the story. There's also engagement for employment and education and others. Here, I've just limited it to the 3 things that we in the hospital or in the clinic setting often are focused on, because those are the services that we are supposed to be good at. And so we often have this paternalistic view that we know better, and the person should just go along and do what we tell them to do. And that is an outdated model. It never really worked to begin with, to be quite frank. But now we've actually hard data to say that it actually doesn't work. And it's not just take the pill and move on, but rather explaining to the person why it would be beneficial to do therapy, because it increases resilience. I always say it's like training for the race. If you want to get in shape, just go to the gym. And that's what you do with therapy. Just prepare yourself for a difficult day. And if you do that regularly, you will be able to weather the storm. And the medication is really just the foundation that allows you to get going on the recovery. It's not going to do anything for you. It's not giving you any directions. It might give you some energy, but not purpose. So what we need is this. And this is really taken from the on-track New York model, which is the one that we also have embraced in Tennessee for our Navigate teams. So there are 3 different kinds of talks that people really need to have. Talking is really important, but not just the traditional talking that we think about as psychotherapy, but talking centered on the individual person, that there are choices, that they can choose between medication or no medication. It is ultimately their choice, not our decision for them. That there are options, that there are different kinds of interventions, and that they can derive, based on their own motivation and engagement, on a decision that then guides them towards recovery. So those are the conversations that happen, and they happen in little bits and pieces. Sometimes there's a really big discussion, but most of the time this takes weeks and months and sometimes years. And it can go in circles, meaning you can go through these talks, make some progress, and then fall back into a pattern where you don't talk anymore. And then you have to redo the cycle again. So this is really how life is anyways. It's not a straight arrow in one direction, but it's more like a meandering path. And that's really what a team can do. That includes people with several perspectives, some of them with lived experience and others with professional experience. and that together we can reach this goal of what I often refer to as bending the curve. So psychosis is somebody throwing you a curveball, and but there is a way for you to improve it. There is a way to make it as good as it can get, and that's our goal. All right, and we are now at about 7:30, so we still have a good amount of time for us to have questions or an open discussion.
So if you guys wouldn't mind either, raising your hands or signaling so that we can, and I see Audrey has a question. Audrey, would you go ahead?
Sure, thank you. I just want to thank Dr. Heckers for being with us, for your expertise. I'm a Vanderbilt grad, so love Vandy. I'm here as a family member of somebody suffering delusional disorder is what we believe. She was not diagnosed. She spent a week at Vandy a couple years ago. This has persisted for about 3 years, and a resistance to medication or ongoing therapy. So I'd love to know anything that you think it's important to share about delusional disorder in particular, and just finding care. That stages of conversation really helped because I do feel like we've been in that circle for 3 to 4 years.
Yeah. So delusional disorder is a little different from many other of the psychotic disorder conditions that are listed. It is one of the diagnoses that I briefly showed on the slide. So it is in the same chapter as the schizophrenia spectrum disorders. But it is different for 2 reasons. First, most individuals who suffer from a delusional disorder avoid treatment at all costs. That means we rarely actually see them. They might end up in the hospital for a couple of days, but they typically can get discharged because they look okay and they can make a good impression. They can have a reasonable conversation, they can argue, they can make their case, and they can even function, meaning they can hold jobs, they can be in a community, they can live independently. So a person with a delusional disorder has, from looking at it from a distance, a milder form of psychosis, but looks are deceiving because that better outcome appearance and that avoidance of treatment leads to this person shaping their entire life around their delusion. And whatever they do, whatever relationships they engage in, it is all under this impression of their delusion. And it's typically a very particular delusion. It's not all over the place. It's typically a well-formed belief system that is often driven by personal experiences. And so the treatment of delusional disorder is, because of the avoidance of treatment, much more challenging. Psychotherapy is actually more important than psychopharmacology, particularly for delusional disorder. But of course, the person needs to be able to trust the person, and that's often the difficult one. The engagement of the person in treatment is often hampered by the fact that the paranoia, as we call it, or the mistrust is so severe that the person simply will not go and simply will not stay in treatment. So, so we at Vanderbilt don't see too many patients with delusional disorder, although they are not that uncommon. The majority of them live in the community and never get diagnosed and rarely get treated. So for the family, it's quite challenging. And so all I can say in this setting, because it really takes a much more detailed review of the individual person. Delusional disorders come in many different shapes and forms, and it really depends on the person's temperament, their personality. So if they are easygoing people, then the delusional disorder might not be as impactful. But if they are what we refer to as neurotic, meaning they are highly anxious, they are very distrustful to begin with, then the delusional disorder can be much more impairing. So the family needs to find a way to be neutral and consistent, which is not easy. But not getting enmeshed in the delusions, not taking sides, not saying yes or no, not disproving that the person is just delusional. So it is a lost battle to convince the person who's delusional, to convince them that they are not seeing the world the right way. So again, being neutral and supportive at the same time, and helping the person see the value of therapy. There are some incentives, particularly if the person provides shelter and food and support and other things, then that is often appreciated. And those supports can then also sometimes be tied with a contingency that they need to stay in treatment and they need to engage in some form of psychotherapy. I hope that's helpful.
Thank you, Dr. Heckers. Uma, did you have a question?
Yes, thank you. Thank you, Dr. Heckers. I have a twofold question. The Navigate program, if it's been a couple of years old, what about the situations for the people who were diagnosed earlier than that? Does this apply to that? That's question number one. And the second part of that is this program only in Vanderbilt, or is it, when you said it is federally approved, is it being practiced in other psychiatry institutions?
Yeah, very good question. Yes, so the Navigate program at this point, as it is funded by many different federal block grants, as they are called, and each state has access to those block grants. As they are funded, they are typically taking patients within the first 5 years of illness, sometimes within the first 2 years. There's some wiggle room. We typically take 2 years of illness. Other programs go up to 5 years. Some programs only take schizophrenia spectrum patients. Others also take bipolar patients with psychosis. We don't. So there are some differences, but in a nutshell, in the early stages, and then for a 2-year period. And once you've completed the program, the idea is that you can then be transitioned to more standard outpatient care, because the capacity of a full Navigate team is 30 patients. That's it. So the entire team is not allowed to really take on more than 30 patients. Kelly, as the Cs, is only allowed to take on 20 patients. And so this is a very...
Hello, Margaret calling.
Margaret, could you go ahead and for us, please? Thank you for coming in, but could you hit star 6, please?
Sure.
Thank you.
So because of that capacity, of course, only few patients would actually be able to get into the program. So we need to make sure that if somebody has benefited, has made progress towards recovery, that they then also make the space available for somebody else. So Kelly, I don't know exactly how many graduates we have. Sometimes you have really good graduates who leave Nashville because they start college or they take a job and don't come to clinic anymore. So those are, of course, great graduations, but I think we had about 5 to 10 graduates so far, Kelly.
Yes, I think we've had about 5 where we've given them like the graduate certificate. Well, we're about to have 2. We're about to have 2 or 3 more actually by the end of this year.
So Uma, to answer your question, so if the person already is into the illness for longer, then they would not qualify for the Navigate team. So that's the answer to the question, the answer to the first question. The second is, in the state of Tennessee, there are several federally funded Navigate programs. They might not call themselves Navigate, they might just call themselves FEPI, or First Episode programs. There's one in Davidson County at the Mental Health Co-op. There's one in, now I'm not particularly good with the counties in Tennessee. Paris, Tennessee, that's Cary Counseling in the western part of the state, and in the Memphis area, in the Knoxville area. And the state has just completed a request for proposals for 2 new programs, one in the Clarksville area and one in Murfreesboro. And I'm not so sure that they have been awarded yet already, but I expect that Centerstone will get one of those, and there might be another community mental health center. But that will be posted on the Department of Mental Health website very soon.
Thank you.
Yeah.
Kelly, I have one quick question for you. When you graduated these people, how long do we follow? Do we follow them up, or do we wait for them to come back? I mean, like, how do we know their progress?
So typically for me, if I'm going to graduate them, they've been with me for 2 years. So that's the average length of time. If they are, maybe they've worked with me for 1 year and they have a job and they're going to school and they're doing really well, I may go ahead and graduate them so I can make room for somebody else. But it kind of just depends on the person. And some people come in and out. They talk to me for a few months and then they disappear for a while and then they come back. But 2 years is about the average.
But I think Uma was also asking, how do we know that the program worked? So we graduate people in 2 ways. They either stay in our clinic and just go to regular clinical care, and that's the majority, or they graduate because they move on and are not even in Nashville anymore. So those are the 2 types of graduations, but it's still too early for us because we are literally just in the first year of graduating some of our patients. So you can ask us again in 2 or 3 years how the program was.
Thank you. Thank you very much.
Thank you. Jessica Schwartzman, did you have your hand up earlier? Did you have a question?
I did not. I
Okay.
appreciate that though.
Thank you.
Christy.
I'm going to go to Christy. I'm going to go to Christy, and then I'm going to go to Nancy.
Mine was on the same thing. I wanted him to clarify something, that's all.
Okay.
Hey, my name is Christy, and I have dissociative identity disorder. And I wanted to ask you a couple of questions. I'm really interested in your program, but I'm not sure like if it's psychosis or, because I do have like, sometimes I'm outside myself, like looking around. So I don't know if that's a hallucination or what, but I don't know if I would qualify or not, but I'm going to talk to Kelly about it. But also I just wanted to see if you knew like much about DID and like medications that might help it, or if I feel like if I knew more about if it's hallucinations or delusions, that I'd be able to kind of work through that better.
Yeah. Well, Christy, you are asking a challenging question, because dissociative identity disorder is one of the mystery illnesses in psychiatry. Nobody really knows exactly how to think about it. And as you most likely know, it really was considered a form of psychosis for many years. In fact, many people would even confuse schizophrenia and dissociative identity disorder, because at the core of both illnesses really this falling apart of that self that really can integrate everything and can hold it together, so that we have like one person telling the story, not more than one. And a person who has dissociative identity disorder can have experiences that are either full-fledged hallucinations or can be akin to hallucinations. We sometimes refer to that as dissociative episodes. And when a person dissociates, they can have sensory experiences, feelings in their body that are like a hallucination. However, we still separate it from psychosis and from hallucinations. To get to the question of the treatment, there really are no good pharmacological treatments for dissociative identity disorder. Psychotherapy is by far the best approach. However, sometimes a person can get very stressed. And when they get stressed, not only do they dissociate, but they can also have frank psychosis. And during those episodes, antipsychotic medication can sometimes help. But it's not a medication that we would recommend for the long term. And it doesn't really prevent the episodes.
Well, do you know what that medication is?
Well, antipsychotics like risperidone or olanzapine,
Oh, okay.
Zyprexa, and others. Yep.
Okay, thank you.
Yep.
Thank you, Christy. Nancy, would you like to add? You said you had something to add on to.
No, I didn't have anything. I wanted him to clarify. I'm sorry, I didn't mean to be rude. I just didn't want him to go on to the other topic. I didn't want to step on anybody's time. When you back to navigate, you said, Vandy, the Navigate's open within the first 2 years of being diagnosed with schizophrenia at Vanderbilt, and the program lasts about 2 years. So there's 2 years and 2 years. Is that kind of what you said?
Yeah, so that means that a person could literally be there from day one of the illness until 2 years, or from the second year, having completed the second year, and then all the way to the end of the 4th year.
Okay, and then it's at Vanderbilt, it's only open for schizophrenia, not for bipolar. Okay.
Yeah, so we try to stay focused on really the original model of Navigate. And the study that I showed you, where I showed you the graphs, this is all for schizophrenia spectrum disorders. Okay. And so some patients with bipolar disorder can be very similar and can have symptoms that are almost indistinguishable. But the majority of bipolar patients do not have that severity of psychosis. So therefore, we try to really limit our team to those who have a significant and serious psychotic disorder.
Thank you, Nancy. Dr. Heckers, I have a question, and it goes back to what you were talking about with blips. And one of the things we often get in our family education classes is a recognition once the education occurs of, oh, that's what that was. Oh, this has actually been going on for quite a while, and often guilt from the parents because they didn't recognize it. There was no way they could have. There's no one ever showed it to them. But the other thing in that stage, when they're in the earlier stages, is the medical community willing to recognize this? Is insurance willing to recognize this and treat it early? Because we are so often told as family members that we've got to wait till someone is almost at stage 4 to treat them. They've got to be really showing florid symptoms before someone will recognize and treat this. What would you suggest to us when to help educate about what the recognition of the blips, and then who to go to for treatment?
Yeah, all very good questions. Let me briefly tell you the story how this evolved in Melbourne, Australia. So a psychiatrist there, Pat McGorry, figured all of those things out that we just talked about 30 years ago. And at that time, he was in a hospital taking care of patients who were acutely ill. They had a psychotic episode, like the unit that we have at Vanderbilt, and the people were so sick that they needed to be admitted. That's what he started out with. And then he said, I have to go upstream. I cannot wait for them to end up in the hospital. I need to find them before they get ill. So what are they doing now, 30 years later? They're not in the hospital anymore. They are not in a clinic anymore. They are not even in any medical center whatsoever. They are in the Green Hills Mall and the 100 Oaks Mall. They are in beautifully colored rooms that play music that a 16 or 18-year-old might be interested in. And they are reaching out and saying, hey, if you have strange experiences, if you have experienced something that is different from what you've experienced before, just drop in, have a cup of coffee, and let's talk. So they have moved the entire model from a medical model to a early detection and intervention model. And they've now done several trials, several clinical trials. And so I can break it down into 3 different take-home points. Medication, not recommended. Fish oil, vitamin D, other kinds of natural remedies were highly recommended, still are a good thing to do, but the recent studies have shown that they're not very effective. And the one thing that really works and that everybody needs to get is good psychotherapy. Not medication, maybe a little bit of fish oil, maybe a little bit of vitamin D, it doesn't hurt. And I would definitely recommend it, but it's not an effective treatment, but psychotherapy, psychotherapy, psychotherapy. In schools, including the family. So that's what the society can do. And that, of course, requires access to therapists, which is not trivial, and recognition for therapy at an early stage. Now, we do have a school-based therapy program at Vanderbilt. We have about 25 full-time therapists working in Davidson County schools. That actually is an environment where that could potentially be implemented. But I'm not so sure that the schools at this point are ready to detect it. And also our therapists are in the schools for, I think it's 1st to 4th grade. So what you really need, you need high school, you need junior high. That's where you need therapists, and you need really good clinicians who can see the blips, not just the full-blown psychosis, but the blips. And they are good instruments, they are good rating scales. You can learn it, you can teach it. And insurance companies will pay for it.
That's good to hear.
Yeah.
That is very good to hear. And something that you did was you also used the word, are you experiencing strange things? And I think languaging is so very important with all of this. And the other thing is when we go out to our diverse community and within the cultural norms of the different cultures that we have here in Nashville, because they may, and I don't know if at Vanderbilt, if you focus on that very much, as far as the difference in someone of, say, a Southeast Asian culture coming in, or as Uma lives with, is that something that you focus on?
So yes and no. I would like to say we do, but it's a mixed kind of, it's half good and half bad, because in the hospital, we take care of everybody. If somebody has a crisis, we take care of everybody. And a lot of our patients are not insured. Particularly when they have the first episode, they have no idea. They don't think they need any health insurance. They're 18 years old, 20 years old. They think they're fine. But in the clinic, we don't really have a clinic for the uninsured. So if the person doesn't have insurance as an outpatient, then they would typically be referred to the mental health co-op first episode program. So that's the mixed message, so that we take care of people in acute setting, but we don't have a clinic really for an uninsured patient.
Thank you. Thank you. Does anyone else have any questions? Christy, yes?
Yeah, I just wanted to thank you also for, you said about, or like one of the graphs and everything talked about having like family, like and friends to be able to support you, and also education for them and things like that. And that's really helpful. I don't have like immediate family, but my husband, like my family anyway. So, but my husband, he's awesome. But it really kind of hit me what you said, because I think shame is in like talking to him about stuff. So I think it's so good. And I think that's one thing that's hindering me for my recovery. And a lot of people's recovery is talking to people like their family and friends.
Yeah.
Thank you.
Well, Christy, I think you hit the nail on the head. If we could remove the shame and then also the guilt, from that, it would become so much easier. We live in an unforgiving society.
Mhm.
We live in a society that takes for granted that we need to be successful. And if we are not successful, then it's our fault. And that's really woven into the fabric of the society. It makes it also very strong, but it's also very unforgiving. And that is particularly challenging for a person who is young, who has not built a solid foundation, who wants to complete education, who wants to have a good job. And if the illness hits you when you are in your 50s and 60s, you might be able to rely on some foundation, and you might also rely on others to help you. But for a young person, that is much more difficult.
Mhm.
And so much more important for us to find out as a society and as a family system how we can support the person without inducing shame and inducing guilt in the survivors, the people who actually are affected by the illness, not because they are experiencing it themselves, but they have a loved one being affected by it.
Thank you. Thank you.
Yes, thank you very much. At this point, if we don't have any other questions, I'm going to close with some announcements. I want to share with those of you that may not be as familiar with NAMI Davidson County that every week, if you sign up for it, Don Liacano, our program coordinator, will share with you on a Monday email what's coming up this week. And so tomorrow night, we do have our Bridges group for people with lived experience. And on Sunday, we have the caregivers only Sunday support group. As Dr. Hecker said, we do look forward to greeting you in person. Right now, things are virtual and online. We also have next week, our fourth Thursday, we have a social group of people with lived experience that meet. It is not a support group. It is a social group. So we do invite you to take a look at our website for the caregiver education that is offered and those things. So that's namidavidson.org. Check out the calendar and other resources there. And we encourage that. For your care, for whatever side of the coin you're on, or if you're on both of them, to do that. I'm going to call out to Kelly Vance with a thank you there, and for the services that you provide and what you've shared tonight. Emily, I think we may have met in the past. It's just occurring to me. Possibly. And Dr. Brennan was on earlier. I happened to see him. I don't think he's still on, but I want to thank him.
He is.
Is he still on? I was
Yep.
looking for him. Where are you, Doctor? There he is. And when Dr. Heckers was saying therapy, all I could think of was Dr. Brennan.
I had a big smile when I said that.
And he was
Okay.
smiling. Yes.
Okay, you're on my second screen, so I couldn't see you. So yes, and so we really appreciate Dr. Brennan has worked with us a little bit, and we look forward to working more with him. So my biggest thanks will go to Dr. Heckers and all that you shared tonight, and how you bring this into the humanity of it. Before I go, I see Rhonda's got a hand up, and
That's a clap.
That's a clap. So Dr. Heckers, thank you for always sharing with such humanity. Thank you so much.
Well, it was a pleasure. And again, as I said, it's always a highlight, and I'm looking forward to coming back, and really let's all work together in next year in person.
Yes, absolutely.